having us be a part of this process. So, to introduce the speaker for today, Dr. Himshika Agarwal. Dr. Himshika Agarwal is an excellent pediatric ophthalmologist, having her private practice by the name of Chinmaya Vision in Paschim Bihar. Dr. Himshika Agarwal is trained from Maulana Azad Medical College, where she did her MBBS, post graduation, and SRship from Guru Nanak Eye Hospital, the Associated Eye Hospital at Mamsi. Dr. Agarwal has also done her short-term fellowship in squint and pediatric ophthalmology from LV Prasad Eye Institute, Hyderabad. Dr. Agarwal is a prolific cataract surgeon, squint surgeon, as well as an excellent clinician and a great human being. And it gives me a lot of pleasure for her to introduce her to start her talk, and I'm looking forward to it.
Thank you, Dr. Ritin. And Dr. Himshika, welcome. Please share your screen. I request all the participants to please mute their Zoom meeting. Yeah, we can see your screen now.
First, good afternoon, everyone. I would like to start by thanking Dr. Ritin for his very kind words. It has been a pleasure working with him, and I think it's his motivation that makes us all want to, work harder. And thanks a lot, Dr. Ritika, for having me here. So we'll start today's topic. So we are going to discuss about squint and nystagmus in children. So I would like to start by asking a question. How many of you have seen a child with squint in your clinic in the last 6 months? You can all raise hands or type yes in the chat box. Yes, exactly. That is why this topic is relevant. So both squint and nystagmus are commonly first picked up by parents or pediatricians, and early recognition can truly change a child's visual outcome. So as pediatricians, you all are usually the first point of contact for children. If squint or nystagmus is detected early and referred, we can prevent amblyopia, which is irreversible lazy eye, if presenting late. Hence, early referral would improve child's vision, confidence, and overall quality of life. So what exactly is squint? Squint simply means the misalignment of eyes. So squinting can be of three major types: phoria, propia, or intermittent. So phoria is latent squint, that is, the squint is hidden and it shows up only when the eyes are dissociated. So only while testing in the clinics can we see such type of squint. Tropia is the manifest form of squint, which is always present, which the patient or the parents will complain of. Intermittent squinting is present at times and controlled at other times. So even if the squint is intermittent, it needs to be managed at the right time so that symptoms of asthenopia, blurring of vision, headache, eye strain can be improved. So in the first image, we see a normal eyes. In here, the both eyes are aligned straight. In the second image, the left eye is turned inward. This is known as esotropia. In the third image, the left eye is turned outward. This is known as exotropia. The eye may be turned up, which is known as hypertropia, or downwards, which is known as hypotropia. So in case of normal eye alignment, both eyes are pointing at the same target and the same image is forming on the fovea of both eyes. And hence the brain combines these same images and we see a single vision. When there is any misalignment in this system, it leads to squinting. So what exactly is happening? So in the first image, in case of esotropia, here we see that the left eye is inturned. So now the image of the object is forming on a non-foveal point. So the eye sees this object in a different direction. So the child is now seeing two images of the same object and hence will present with double vision or diplopia. Similarly, in exotropia, again the child will see two images of the same object and will complain of double vision. The brains of children are very adaptable. So, in order to compensate or manage this double vision, what they do is they start suppressing or ignoring one eye. So, they only see from the eye which is aligned straight. And when they constantly suppress or ignore one eye, the vision of that eye gradually starts to decrease, which leads to amblyopia, what we are most worried about. So the vision development usually occurs by 8 to 10 years of life. So if not managed during that period, this could lead to a permanent decrease in vision. So who are the children who are at risk of developing squint? So children with refractive errors, especially high hypermetropia, that is plus power, or anisometropia, that is the power in the two eyes are very different, are at higher risk of developing or having squint. If they have a family history of squinting and certain genetic syndromes like Down syndrome, Klinefelter syndrome, Cruzen syndrome, Apert syndrome, golden hour syndrome, are at more risk of having squinting. Then perinatal and developmental history is also very important, as children with prematurity, low birth weight, perinatal hypoxia, birth trauma, or intraventricular hemorrhages are at a greater risk of having squint. Neurological conditions like cerebral palsy, developmental delays, hydrocephalus, and seizure disorders are also associated with squinting. Usually, the child or parents might complain of deviated eye, that the child's eye are turned in or out, or they feel that something is wrong with the child's eye, or they may come with double vision. So usually children do not complain of double vision, they just start closing one eye, because diplopia in squinting is always binocular diplopia. So that is that the children will see double only when they are seeing with both eyes. As soon as they close one eye, they see single vision, and that is why they develop a habit of closing one eye. So the child may also present with an abnormal head posture. Like in the first image, we see that the child is turning his head towards right. In the second, there is a prominent head tilt. And in the third, chin up position. So the children usually adopt these head postures to compensate for the diplopia, because in this posture, they are not seeing double. Or they could also do this to increase their field of vision if their eyes are not moving fully in all the directions. So we can do some simple tests in our clinic to detect squint. These do not require any special instruments or equipments. So we'll be discussing the following tests in the coming slides. One is the corneal light reflex, cover uncover test, red reflex test, and extraocular movement assessment. So in the corneal light reflex test, what we do is we just need a torch light, and we shine the torch between the two eyes of the child and see the reflex of the torch light in the child's eye. So in the first image, we see that the light reflex is formed in the center of the pupil in both eyes. It is symmetrical, and hence the child is orthotropic, that is, he has straight eyes. In the second image, we see that in the right eye, the reflex is at the center of the pupil, but in the left eye, the white reflex is towards the temporal side. So that is, the eye is turned inwards, the child has esotropia, and because of which the reflex is seen towards the temporal side. In the third image, we see that the reflex is towards the nasal pupillary margin, and hence the child has exotropia, that is, the eye is turned outwards. So these are images of three children. In the first image, the light reflex is central. This person is orthotropic. In the second, we see that the light reflex is near the nasal limbus. So the child is exotropic, that is, the eye is turned outwards. And in the third image, we see that the light reflex is towards the temporal limbus, that is, the child is esotropic. In some cases, when the squint is very small and the child is not looking straight and we are having very difficulty in assessing the light reflex test, we can also do the cover test. So what we do in the cover test is done in case of manifest squint, when we can observe the squint in the eye. So what we do is we cover the eye which looks straight. So as soon as we cover the eye which looks straight, the eye which is deviated moves towards the center to start seeing. So in the first image, we see as soon as we cover the right straight eye, the left eye, which was turned inwards, moves in to out to take fixation as the child now starts seeing from the left eye. So this in to out movement will help us to detect that there is esotropia or inward deviation in this child. In the second image, we see that when we cover the normal right eye, the left eye moves out to in to take up fixation. So there is exotropia. In the third image, when we cover the right normal eye, the left eye, which was drifted upwards, now moves down to take up fixation. So this up to down movement tells us that there is a left hypertropia. And in the last image, there is left hypotropia, and hence on covering the right eye, the eye would move up. In some cases, the squint may be latent or intermittent, and we cannot observe squinting. So we can do a cover-uncover test to assess this. So we cover any one of the two eyes, and what happens is the eye which is under cover will move to its comfortable position, like its position of rest. So in an esophoric patient, the eye under cover will move inwards. But as soon as we remove the cover, we'll see that the eye again moves back to its central position to take up fixation. So we see an in to out movement. And in this way, we can detect that the child is esophoric. The opposite will happen in exophoria. When we cover one eye, the eye under the cover will take its position of rest, that is preferred position, that it'll move outwards. As soon as we uncover the eye, the fusional mechanisms will again act and the child will start fixating with the both eyes and the eye will move out to in. So this will suggest exophoria. So these cover uncover test and alternatingly covering the both eyes, alternate cover test, can help us in detecting phorias and intermittent squint. So here is a video which shows alternate cover test to detect squint. We see that this child's eyes are moving in to out. So this child has esotropia. Again, we see an in to out movement in the eyes of the child, and the child has esotropia. So we do not need any special occluders to perform this test. We can just cover the eyes with our hands or fingers or whatever. Even then we can demonstrate this easily. So an in to out movement, this is esotropia. Here we are making the girl fixate to an object and then we are doing the alternate cover test or the cover uncover test. We see an out to in movement. That is, the child is exotropic and hence is having an out to in movement. This child has a right upward deviation. Right eye is hypertropic. So on cover uncover test, we see that the right eye is moving down. And this confirms that the child has right hypertropia. We can also do a red reflex test or a Bruckner's test in our OPDs. So what happens is we need a direct ophthalmoscope and we just observe the red reflex in both the eyes together. So any asymmetry in the color or brightness of the reflex indicates that there is something wrong with the eyes. So the eye which is squinting will have a brighter and a lighter reflex. Even in cases where the refractive error in the two eyes is very different, the reflex would be asymmetric. Also, this test would also help us in diagnosing some more serious conditions like congenital cataracts or retinoblastoma. Next, we need to assess the ocular movements of the eye. So, because this will help us to tell whether the movements are free, this will help us to reach out to tell the pathology, give us an idea about the pathology of the squint, whether it is restrictive or paralytic. So, usually we check movements in elevation, depression, left up gaze, left down gaze, right gaze, and right up gaze. Usually, it is very difficult to assess these movements in very small children. What we can do is we can perform an easy, like we check the doll's eye maneuver. We can just rotate the head of the child towards right and left and see whether the eyes are moving till the corner of the eyes or not. So next, I would like to talk about an entity called as pseudo-esotropia. So there are a lot of children who we see and we think that there is esotropia, but actually they're not having esotropia or exotropia. It's just that because of their facial features, it appears that the child has squint. So in such patients, the corneal reflex test, the Hirschberg test would be central, and there would be no movement on the cover uncover test or the alternate cover test. So pseudo in the first image, we see that the child has prominent medial epicanthal folds and a very flat nasal bridge, which gives us the apparent appearance of a right esotropia, although the light reflex is central in both eyes. Similarly, in other two, because of the flat nasal bridge and epicanthal folds, it appears as the eyes are squinting. Again, pseudoexotropia could be due to hypertelorism. The distance between the two eyes is large, a wide or broad nasal bridge, large interpupillary distance. Again, corneal reflex test would be central and there would be no movement in the cover uncover test. Next, I would like to discuss about comitant and incomitant squints. What usually the congenital squints we see in our OPDs are mostly comitant. So comitant squints are those in which the deviation is same in all direction of gaze. That is, the amount of squinting is same when the child is seeing straight or left or right. Whereas in incomitant squint, the deviation is different in different gazes. That is, the child may have a smaller deviation when he is looking straight, which may increase in the left or right gaze or while viewing up or down. So the comitant squint usually has a childhood onset, and it could be sensory or refractive error related to refractive errors or idiopathic. Whereas incomitant squint can be paralytic, restrictive, or due to mechanical causes. Comitant squint has an insidious onset and usually presents early in childhood. Incomitant squint has a sudden onset and it can be acquired due to nerve palsies, cranial nerve palsies, the third nerve, fourth nerve, or the sixth nerve palsy, due to trauma, thyroid disease, or myasthenia. In comitant squints, diplopia is very rare because usually these are very early childhood onset squints, and the child develops suppression or amblyopia to overcome the diplopia. Whereas in incomitant squint, due to a sudden onset, the children or the adults usually present with diplopia. Abnormal head posture is uncommon in comitant squint and more common in incomitant squint. Again, to minimize diplopia, the children adopt an abnormal head posture. Ocular movements are full and free in comitant squint, whereas they are limited or restricted in incomitant squint. So the common cases of comitant squint that we see in our OPD on a day-to-day basis. So in esotropia, there is a very important entity called as accommodative esotropia. Here, the child usually presents at 2 to 3 years of age and usually has a high plus number. Because of this high plus number, he starts to converge more so that he sees clearly. Because of this excessive convergence, his eyes drift inwards. The only thing that we need to do is we need to check his refraction. We do need to do his refraction, that is, check his glasses number and prescribe in glasses, and the child will have straight eyes with the glasses. That is all that we need to do. So refraction or vision checking and the checking of the eye number is very important in every case of squint, because some squints can just need glasses to be corrected. So there's another entity called as partially accommodative. So this kind has an accommodative component, so that when we prescribe this child glasses, the squinting will improve, but will not be corrected fully. The non-accommodative causes include infantile esotropia, which is very common form of squint that we see. So usually the children present before the 6 months of age, and they have large angle constant esotropia. Usually they also have nystagmus associated. Then acute comitant esotropia. So again, this is a comitant form of esotropia, but presents acutely. So the child would present with diplopia. And it is very important to investigate for any neurological condition in such children. Then common causes of comitant exotropia include infantile exotropia. Infantile exotropia is again early onset, before 1 year of age. It is large angle, constant, and alternate exotropia at such a young age is very rare. So we need to investigate these children for neurological conditions. And intermittent exotropia, here the child, when he's daydreaming, when he's tired, when he's not focusing, his eyes have a tendency to drift outwards. But then when he's alert, the eyes again become straight. So such children were present with headache, eye strain, blurred vision, and occasional double vision. If the frequency of squinting is more, they may require therapies like vision therapy, eye exercises, or even surgery, and we can easily correct this type of squints. Then common causes of concomitant squint include paralytic, neurogenic, or myogenic, which includes the third nerve palsy, fourth nerve palsy, or the sixth nerve palsy. And the restrictive ones are the congenital restrictive squints like the Duane's retraction syndrome, DRS, the Brown syndrome, congenital muscle fibrosis. And acquired forms of restrictive squint include thyroid disorders, parasitic cysts of the muscle, trauma, or orbital tumors. So here is a child with third nerve palsy. We see that the child has ptosis and his eyes are down and out. The congenital third nerve palsy is common. We need to check the pupils to see if the pupils are involved or not. And if it is not congenital and it develops at a later age in a child, it needs neurological evaluation. We need to do neuroimaging to rule out other causes. In fourth nerve palsy, so usually children with fourth nerve palsy present with abnormal head posture. They have a head tilt to compensate for the double vision. So as soon as they tilt their head, their double vision improves, and gradually, because of this constant abnormal head posture, they may develop torticollis or stiff neck and facial asymmetry as well. So congenital superior oblique palsy may present at a very young age, and at times it can present in adulthood also. So the child is having large fusional amplitudes which may break one fine day, and even congenital palsies can present in adulthood. And sixth nerve palsy. So a patient with sixth nerve palsy would present with esotropia, double vision, and a face turn. So he adopts this face turn to increase his field of vision and to overcome the diplopia. Congenital sixth nerve palsy is very, very rare. So usually these children are misdiagnosed. Either they have infantile esotropia and an apparent abduction limitation, which we have not checked properly, or they have Duane retraction syndrome, because of which they have an abduction deficit. So per se, congenital sixth nerve palsy is very rare. Rarely it can occur due to birth trauma. So a child presenting with sixth nerve palsy does need neurological evaluation. It may be a bilateral sixth nerve palsy, may be a false localizing sign for raised intracranial pressure. So any child with sixth nerve palsy does need urgent neurological evaluation. What are the red flags, or when we need to refer urgently these children? So if there is a sudden onset of squinting, abnormal red reflex, or a squint with diplopia in older children, associated neurological signs like vomiting, headache, bulging fontanelles, or ataxia, we need to refer them early. And any fixation preference. So many of these children are basically alternate squinters. That is, the squinting is alternate. So sometimes it's the left eye which is squinting, sometimes the right eye is squinting. So they are at a lower risk of developing amblyopia. But the children which have a fixation preference, that is, usually one of the eye is squinting more, they are at risk of developing amblyopia, and hence we need to pick these children faster and refer them earlier to prevent the development of amblyopia. So in pre-verbal children, there is a very simple way of checking for fixation preference. So what we do is we close one eye and we make the child see an object of interest. So we see that when we are closing the better eye through which the child can see, he suddenly turns irritable and he tries to remove your hand. But when we close the worse eye, the child is happier. So this can give us an idea if the child has a poor vision in one eye, is preferring fixation from one eye. These children need to be referred early so that we can give them exercise or perform surgery so that gradually their eye growth, eye vision development can catch up. So why should pediatricians care? So squinting is not just cosmetic. It causes amblyopia and can lead to decreased vision. Then there is something else called as loss of binocularity or binocular vision. So children with squint, even when they have a 6/6 vision, their binocular vision is very poor. So they have poor depth perception, poor stereopsis. Because of this, they may have problems in future, like they may be poorer in certain sports activity while using microscopes, etc. They might have a poor school performance, low confidence, psychosocial issues. Therefore, even if intermittent squinting, we need to refer them early so that we can either give them occlusion therapy or vision therapy in the form of exercises, or perform surgery early so that they can even develop binocularity. So these are cases which we have done. Like this child had an exotropia, and post-op she has straight eyes, and now she's on vision therapy to improve her stereopsis. This again is a child 6/6 vision, alternate divergent squint, and doing well after surgery. So these children will improve, and timely surgery will even help them develop stereopsis. Coming on to the next topic, that is nystagmus. So nystagmus is an involuntary, rhythmic, repetitive to and fro movement of the eye. So broadly, it can be categorized into infantile nystagmus, which has an onset less than 6 months of age, or an acquired nystagmus, which could be due to ocular or neurological causes. Then nystagmus can be jerky or pendular. So jerky nystagmus has a fast and a slow component. Pendular nystagmus has equal velocities in both the directions. What are the common causes of infantile nystagmus? So usually very poor vision. Conditions that cause very poor vision since birth will lead to infantile manifest nystagmus like albinism, aniridia, Leber's congenital amaurosis, bilateral optic nerve hyperplasia, congenital cataracts, achromatopsia. Then there is something called as infantile latent nystagmus. So what is this in latent nystagmus? We do not observe any nystagmus, any eye shaking when we see the two eyes together. But as soon as we cover any one eye, the eye starts shaking to and fro. That is, we observe the nystagmus. This is called latent nystagmus, and it is very common with infantile esotropia. Then there is something called as a manifest latent nystagmus. So here, nystagmus is always present. So even when the child is seeing with two eyes, his eyes are moving to and fro. There are nystagmus movements. But as soon as we cover one eye, the amplitude and the frequency of the nystagmus increases. So this is called as manifest latent nystagmus. In nystagmus blockage syndrome, so we usually observe that the amplitude of nystagmus decreases when our eye converge. So some children, in order to overcome this nystagmus, they go into an esotropic position to decrease the amplitude of nystagmus, to decrease nystagmus. So usually they present not with nystagmus, but with esotropia, but actually have nystagmus. Common causes of acquired nystagmus include any reason secondary to visual loss, toxic or metabolic causes, some drugs, Wernicke's encephalopathy, neurological disorders like tumor, trauma, multiple sclerosis, stroke, thalamic hemorrhages. So what we can pick up in our clinics, any abnormal head posture. So some children with nystagmus have a null point. So what this null point is, so in some direction of the gaze, their nystagmus decreases. In when viewing towards the left or right, the nystagmus decreases. So now the child turns his face and sees in that position of the gaze only, because there the nystagmus is less. So this is known as the null point, and we can correct this abnormal head posture with surgery. So the child might present with a normal head posture. The parents report that the child's eyes are shaking. The child may not fixate properly. He may have poor vision. There may be squinting associated with nystagmus. So, what are the indications for neurological evaluation for nystagmus? So, any onset after 6 months of age, sudden onset of nystagmus associated with oscillopsia. That is, the child is complaining that there are visual disturbances due to the eye movements. He feels as if the world is also shaking with his eye movements. That is oscillopsia, and it is more common with vestibular causes of nystagmus. Presence of any neurological signs like weakness, ataxia, seizures, developmental delay, vomiting, bulging signals, or other signs of raised intracranial pressures. Any asymmetric nystagmus, that is, there is asymmetry between the two eyes, or vertical nystagmus, upbeat, downbeat. Upbeat nystagmus is more common with cervicomedullary medullary junction lesions, downbeat with cerebellar vermis lesions. So, any nystagmus changing directions with gaze, or if there is a history of trauma, acute illness before the onset of nystagmus, there is seesaw nystagmus, which is associated with paracellus tumors. All these conditions will require neuroimaging and urgent referral for neurological evaluation. So another interesting condition is called spasmus nutans. Here, the child presents in infancy with head nodding, an abnormal head posture, and variable asymmetric nystagmus. So he may have a torticollis, usually adopts an abnormal head posture for the nystagmus. We only need to do a neuroimaging to rule out optic nerve gliomas, because they may rarely be associated with this. If the imaging turns out to be normal, this has a benign course and resolves on its own by second to third year of age. So, what are our key take home message? So, squint can be vision threatening. Early detection prevents amblyopia. Avoid saying it will go away on its own. We see a lot of patients, like some relatives have said that surgery should be done only when the child grows up, it will go away. I think whenever in doubt, a referral to an ophthalmologist is important, because even if we decide not to operate, we can start amblyopia therapy, we can start exercises so that at least vision develops fully in the child's eye. So, nystagmus needs detailed eye and neurological evaluation, and whenever in doubt, refer. Thank you so much for your kind and patient listening. We're open to the discussion now.
So, thank you, Dr. Himshika. I think you've covered a really vast topic of squint and nystagmus. Uh, just to summarize, just to put some of these points together, I think that treating children with ocular problems, it requires a three-sided effort. Especially with things like squint and nystagmus, we need uh, we need the pediatrician to first identify that there is probably something going wrong with the patient's eyes. That's going to be the first point. Then these patients need to be evaluated by a pediatric ophthalmologist, not just any ophthalmologist. Being an ophthalmologist myself, I can tell you that while I'll be able to identify, diagnose most of these diseases, it'll be tough for me to pinpoint exactly what's going on. The right tools should be available at hand all the time for me to be able to assess the degree of squint, the correct muscle, the correct problem that there is, and how aggressive that we need to treat. So I think it's a specialized skill, and it needs a specialized consultation. Third, I think the role of a pediatric neurologist cannot be, emphasized more in these cases because uh, Squint and Nystagmus, they are a part of neuro-ophthalmology and are very frequently associated with neurological conditions. Apart from this, as a pediatrician, the first thing that I would say is that please make it a habit to examine your patient's eyes. Just a simple torchlight examination of patients at the age of 1 or 2 years will give you a host of different things. I don't expect you to remember all of these tests, all of these things that are going on, but if there are just two simple things that you want to see, one is the corneal reflex, that whether it seems central, and if you could learn the alternate cover and the cover uncover test, you'll be great at diagnosing that patients have squint, and you can stop at that and refer. Look at head positions. If you're looking at, if you see patients with unusual head positions like face turns and head tilts, don't ignore them. These are important things. And just by catching this early, you're going to save, the child from a lot of trouble. Squint is a symptom of something that is probably going on in the background. If you catch the squint, you could catch the disease and you could fix both just by early referral. So I think that's really important.
Doctor, I would request Dr. Rajni Farmania to also give her inputs.
So thank you, Dr. Himshika, to make us more aware and alert. And it was a really fantastic presentation and a very enlightening session for us to simply examine and learn the importance of how to examine and refer. And I, being a pediatric neurologist, I see a lot of cases with squint with CP. Since we deal with developmental delay and CP, they have a lot of squint, and their only question which come to me is, "Ma'am, isko kaise theek kare and kya kare?" So what we usually tell them is a patch therapy, occlusion therapy. Yeah, do get it for the eye thing, and we advise for patch therapy. So we want to know more about patch therapy. What to advise to kids? Hello.
Yeah.
Yeah, we can hear you.
Yeah. Dr. Himchika, please.
Yes. So, ma'am, in patch therapy, so if like the child is pre-verbal, very small child, and you see that he doesn't have a fixation preference, like it doesn't grossly seem that the vision only in one eye is poor. So sometimes he's squinting one eye, sometimes the other eye, not always from the same eye. So we give them alternate patching. So now what we suggest is only 2 hours of patching is enough. So 2 hours a day. One day they patch one eye, the other day they patch the other eye. And while doing that, whatever the child so in very small children, again, give them toys with lights, bright colors, so that they're involved, and tie the any toy with light or yo-yos with strings, and ask the child to just follow that light source in a dark room. So in very poor like children with very poor vision, so if we see that only one eye is poorer, so that the child has a fixation preference with one eye and the always squinting with the other eye, so we would like to patch the better eye, so that he starts seeing from the squinting eye or the worse eye. He's forced to use that eye. Again, ideally, in this case, it would be better if more hours can be done, but at least for 2 hours a day. So what we usually do is, till this age of 6 years, what we follow is, if the child is 1 year old or less, so we give them alternate patching. So one day they patch the better eye, the other day patch the worse eye, because the risk of something called as reverse amblyopia is very high in these children. So what happens is, if we constantly patch the better eye, the vision of the better eye starts decreasing. Then at the age of 2 years, what we prescribe is 1:2. That is, for 2 days, they patch the better eye, and on the third day, they patch the worse eye. And then 3 years, 3:1. So 3 days we patch the better eye. Then fourth day we patch the worse eye. Again 3 days the better eye, and fourth day the worse eye. Then at age 4:1. 5 years, 5:1, and then 6 and onwards, 6:1. So there are 7 days in a week. So the child would, a 6-year-old or above, would patch his better eye for 6 days, and then the worse eye for the seventh day. So we're doing this just so that he doesn't start developing amblyopia in the better eye also. So that is what we do. And apart from patching, there are a lot of other therapies. Like we have, so children with relatively better vision, we give them computer games or for them to develop binocularity. So we have other softwares as well. So we can refer them for that as well. So even that is now coming up in the treatment of amblyopia or poor vision.
So thank you for the detailed description about the age and the number of hours. And I was not aware that you have to patch the worse eye also sometimes a day. So that the good eye also. Basically patching the worse eye, the symptomatic eye also. And when to do surgery in squint? Suppose I have a child of CP and they have been doing patch therapy with a poor compliance because sometimes kids are non-cooperative. So when do we advise them surgery?
So, ma'am, what happens is our first aim is to correct amblyopia. We need to follow these children. So when we know that the vision is already very, very poor in the eye, the child has a neurological deficit, HI, MRI, HI changes and everything. We know that the child will have poor vision, and even with amblyopia therapy, vision therapy, this is sometimes difficult to manage and improve. So what we do is actually we can undergo surgery at any age. So there is no right age, like we have to wait till this age. So whenever we feel that the child is cooperative and we can assess the amount of squinting correctly, as in what degree of squint is there, when I've seen him a few times and I'm sure that amblyopia therapy is not working, and after explaining the prognosis, we can undergo cosmetic squint surgery. Again, they will have to undergo patching even after the squint surgery. So only surgery will not improve their vision. So if they have poor vision, they will have to continue with patching therapy or vision therapy. But per se, surgery, there is no right age for surgery. So already children who have dense amblyopia, they can undergo surgery at any age. It's just that whenever they're cooperative enough, when we know, yes, this deviation is this much surgery will do, we can plan a surgery.
If a child is not taking patch therapy, totally non-cooperative, and there is no scope of doing it even after surgery, do we still advise them surgery?
Ma'am, in such cases, surgery would be more cosmetic. So again, we have to explain the prognosis, because for vision improvement, this might help, but again, patch therapy, he will require something or the other. So what we can do is
Some of
sometimes
they
we
have
put
lot of
atropine eye
also.
drops in like the better eye. In very uncooperative patients, what we do is we give atropine eye ointment or home atropine eye drops so that the better eye is dilated. So now he's seeing blurred from that eye and he's forced to use the worse eye. In some cases, we can even try that as well if the child is very uncooperative or something like that.
And how long will that last? The effect of the drop will last?
Ma'am, that'll have to be put on a regular basis. So because till the time the therapy is going on. So yes, in very small children we can do that. In school going children, if the vision is very poor, very poor in the other eye, then it will be a bit difficult. But in babies or very small children, we can try that.
So just to add to this,
So, the audience, if somebody has some question, maybe we can take some questions.
yeah.
There are no questions in the chat box.
So, just to add to this, Dr. Farmania, one comment that I wanted to say is that ultimately our main goal is to prevent amblyopia from setting in for these patients. You know, we don't want these patients to go into amblyopia. But please understand that amblyopia alone is a diagnosis of exclusion. Diagnosis of exclusion. So before we actually start treating the amblyopia, there's an entire workup where we exactly find out what is the cause of the poor vision in this eye. Is it that the squint, is it anisometropia, means there's a difference in the refractive error which is causing it? Is there an organic lesion somewhere inside the eye? Or is it because of the squint? You know, so squint causes amblyopia as well as poor vision causes squint. So both of them are kind of interrelated. If we end up doing a squint correction for a patient and not treat the vision, these patients squint will come back. You know, it's possible that it might come back, and surgery hasn't helped too much as well. So amblyopia therapy is the ultimate goal, but the initial workup is really important to find out exactly what the pathology is. Treat the pathology first. Once that we have fixed it, and now let's start working on the amblyopia. That is next. So, you know, if you don't give the child corrective glasses, I'm not so sure that amblyopia therapy will really help you too much. So it's with the corrective glasses and patching, not just patching alone. Yeah.
Okay, so
Okay.
we
So
have
the
a
only problem is kids with behavioral disorder, they don't keep specs and they don't do patching. So worst case scenarios, they are not compliant to the conservative measures. Uh, there is a comment in the chat that infantile onset nystagmus with latent component advised not to do any patching. Best is to give glasses. Okay, there's a comment on the question which I asked to give contact lenses and observe respond. Nystagmus pattern, watch head posture. Okay. So thank you for this comment, Dr. Sakshi. I did not get the question, Dr. Ritika, here. You said that there are two questions.
no, I said there's a comment. I was going to tell the comment which is there in the chat box.
Yeah. So it was a real enlightening session and we learned a lot.
So, thank you so much, Dr. Himshika, Dr. Ritin, and Dr. Rajni for taking out the time. And this discussion was actually very fruitful. It has literally opened our eyes. and thank you so much to all the participants who also took out time on a working day to attend this interesting discussion. We'll be coming up with more such interesting topics next month. And on behalf of BLK Center for Child Health as well as IB Central Delhi branch, I thank you all and I wish you a very good afternoon. Have a nice day.
Thank you.
Thank you.
Thank you so much.